Thank you so much. This is our 2025 Sarcoma Patient Education and Caregiver Educational Program. Thank you for dedicating your morning to spending this with us. This is our land acknowledgement, acknowledging that Fred Hutch is on the land of our native tribes, and so we want to acknowledge them. And we are both of your event chairs that will be helping to moderate these sessions. We will be looking at the chat to address questions as they come up at the end of each panelist sections. And I am Stephanie Schaub. I may know some of you. I am a radiation oncologist and assistant professor in the Department of Radiation Oncology at the University of Washington and Fred Hutch.
And I'm Jeremy Sharib. I'm also assistant professor in the Department of Surgery, and I'm an abdominal surgical oncologist at the University of Washington and Fred Hutch.
Just a few bookkeeping items. This event will be recorded. Please post your questions in the chat function. We try to remind everyone to try to keep their questions broad and generalizable to the greater community. But if there are specific questions in regard to your specific setting, you can always ask your oncology team in the coming weeks. If you end up leaving a Zoom webinar for any reason, you may rejoin by clicking the link that was sent to you in the event details. Post-event, please fill out the event feedback form. This helps us to make this event more tailored to you and to address what you would like to see for future years. The last thing is that this event will be recorded. So if for some reason you need to leave, know that you can always tune in to sessions afterwards.
Thank you so much, Stephanie. We have a really packed but informative agenda for this morning. In the early session, we'll get a chance to hear from the medical oncology, pathology, and surgery perspectives from various aspects of sarcoma care. And then we start the later session off just after the break again with a radiation and some integrative oncology approaches before hearing from some of our partners. So hopefully you have a chance to be here for the whole session, but if not, take a quick look at the breakdown here, and there's opportunities to come in and out throughout the day. Thank you all again for being here on time. We are a couple minutes early, but I think that'll be helpful maybe on the back end. And now I would like to present our first speaker, Dr. Elizabeth Loggers. She is an associate professor of hematology and oncology at UW Medicine and Fred Hutch Cancer Center. She's also the medical director for supportive and palliative care. And on the sarcoma team, she's a medical oncologist and the interim director for research for the Fred Hutch Sarcoma Program. And she's been our instrumental leader over the last several months in this time of transition that we are in. Without further ado, would love to introduce Dr. Loggers.
Well, good morning, everyone. It's a pleasure to be here. I'm going to try to share my screen and get started. Thank you for that kind introduction, Jeremy, and to our wonderful program chairs for allowing me to be here. It's actually been a very interesting time just in the last, 6 months for systemic therapy for sarcoma. So it's great to be here. I do just want to disclose that I'm going to be talking about a number of different therapies that are given for sarcoma. And I have been a PI for the companies that own these products. And so this is just informational. These are the 3 topics that I'm going to try to touch on in the 20 minutes that I have. I'm hopeful that I can keep it to 15 minutes and leave 5 minutes for questions. But if there's a pressing question, please do use the chat. And if it's obvious that it's important for understanding, I'm hopeful that the chairs will interrupt me so that I can make sure that I'm, keeping everybody informed and clear on what we're talking about. So I'm going to start with afami-cel, and this is the reference to the primary paper that was published on this topic, but there are, of course, a number of different papers that support all of this work. This is an immune therapy, and immunotherapy is a kind of a broad term. It talks about therapies that basically modify the immune system of the individual to better fight the cancer. Some immunotherapies are very generalized, like you'll see here, immune modulators. These are usually chemicals that are secreted or that are introduced purposefully. But some are really very focused on the immune system. And we're going to talk today about what's called adoptive T cell therapy. So that's why that's highlighted. There are two kind of major classes of adoptive T cell therapies that you're probably seeing in the news and getting excited about. The one that you've heard the most about, I'm sure, is CAR T cell therapy, where basically we're taking a person's T cells out of their body, genetically modifying them to be able to attack the cancer better, and then growing them outside of their body and then giving them back. In the hopes that those cells will basically be kept by the person, persist in their body, and continue to fight the cancer. But there's another kind of adoptive T cell therapy, and that's called T cell receptor therapy, or TCR. And the way that this is different is that TCRs require that the person's blood type, their histocompatibility complex class 1 or MHC1, is a particular type. Because they've modified the T cell receptor using attached to that, to that MHC. So you can see that in this panel here. So not everyone is eligible for this, not just because they don't have the protein that's on the surface of the cancer cell that we're specifically targeting, but also because their blood type, their HLA, may not be the right match. And so that's just important because it tells us a little bit about how easy or difficult it is to actually act on these in the clinic. There are 7 approved CAR T cell therapies. The vast majority of those are actually in blood cancers, but there is now one TCR that's approved in sarcoma, and that's the one I'm going to talk about, and that's afami-cel. It's got a much longer name, which I honestly have trouble pronouncing, so I'm going to call it afami-cel. This is a T cell receptor therapy against what's called melanoma antigen A4. This is what's also called a cancer testis antigen. And again, this can be presented either inside the body of the cell or out on the surface of the cell. And that allows the TCR, the T cell receptor therapy, to actually attack this. So this was just approved in August. It's not even yet available at Fred Hutch, but we are rapidly working to make sure this is available for advanced synovial sarcoma. The original trial that led to this approval actually was conducted in people with synovial sarcoma and with myxoid round cell liposarcoma. These are two translocation-associated sarcomas, and both of these tend to present MAGE and another cancer testis antigen, NY-ESO. And the reason I tell you about both of them is because we know that there's still a lot of ongoing work to try to target NY-ESO as well. So while we're thrilled that we have this MAGE-A4 treatment, we're also excited to see whether or not the NY-ESO version will also get expression. These are really important because immunotherapies haven't been particularly effective in sarcomas broadly. There's just a few subtypes that seem to work for this well. Sorry, going wrong direction. This is a little bit more about the trial, which was called Spearhead, and it was called Spearhead because they named this a specific peptide antigen receptor, so Spearhead. And these are just the eligibility. So you had to be really in good shape to do this. And like I said, have the HLA and have MAGE on the surface of your cell. And you had to have previously received what would be considered the standard of care, which was anthracycline or ifosfamide. You saw that picture of CAR T, and it's very similar, that the T cells are being taken out of the body, genetically modified and given back. In this case, people just got one infusion, and then they were followed, and they didn't get other treatment until their disease progressed. And so we were trying to understand, well, how well did they do, after that one infusion? And this just, I wanted to highlight this because I wanted to just impress upon everybody how amazing this effort was to enroll people in a very rare cancer, or two very rare cancers, but also how hard it was to do. So they started enrolling this in 2019. So 5 years ago, this work, started, and the enrollment ended in 2021. There were 44 synovial sarcoma individuals with synovial sarcoma and 8 individuals with myxoid round cell liposarcoma. And only 28 of those who were pre-screened actually were positive for both the HLA type and the MAGE. And so you can just kind of see people kind of falling off at each step of the way until only 52 people out of the 373 people who we originally screened actually were able to receive it. And so it's difficult. This is hard work. Only 14% of those undergoing pre-screening actually got this. This is called a waterfall plot, and you can probably imagine why, right? It looks like a waterfall, and we really hope that it looks like a waterfall because the people that are going, the cases that are going downward are people who got a response to the therapy. The bars that are standing up are the people who unfortunately their cancer got worse despite the treatment. And so that's kind of the mountain as opposed to the waterfall. Those little asterisks are people who had myxoid liposarcoma instead of synovial sarcoma. But the blue are the people who actually got a partial response, which means that some of their cancer shrunk, but it didn't go completely away. Overall, the response rate was about 37%. And so still, a lot of people didn't get a partial response. More people, there were a number of people who also got stable disease, but for that definition of response, they're talking about people who actually had shrinkage. This is a lot like a waterfall plot, but kind of turned on its side and showing what happened over time to each of these people. So the people below that red line are the people who got a response or got stable disease, and they're, you can see they're in different colors. And this is just showing how over time people continue to have a response. And I've drawn in this black line to show approximately a year. And this is really important because you can see it continues well on beyond a year. And this was, not something we've seen really in synovial sarcoma in general before, where some people really did very well for a long time, even after just one infusion. So the median follow-up time was basically nearly 3 years at the time that the paper was published. And so this has been really important. Most people saw a response pretty quickly. And then the duration was the median duration was about 12 months or 1 year. And so again, this was super exciting news. This is what's called a survival plot, where we're basically, again, looking at people over time and seeing who continues to respond over time. This study, everybody got the TCR. So this isn't a comparison to other people. This is really comparing the people who responded to the people who didn't respond. So the responders here are the blue upper line, and the people who didn't get a response are the red line. And it's just showing that if you got a response, you did better. And these are called Kaplan-Meier plots, basically, of overall survival. So what was great was that if you got a response, then you were 90% likely to still be alive at a year and 70% likely to still be alive at 24 months or 2 years. This wasn't without toxicity, though. This is showing different grades of toxicity. We do this to try to understand how serious the problems were that were associated with this. You don't see grade 5 on this table, but grade 5 means that someone actually unfortunately died because of the actual treatment itself. 1 and 2 is mild, where we don't usually need to do anything about it. 3, we usually have to do something about it, but you're not necessarily hospitalized. And 4 means you actually got hospitalized because it was so serious. And these adoptive T cell therapies have very interesting toxicities. You can see on this, cytokine release syndrome is the number 1, and it was generally mild, but 70% or so of people, actually 71% of people actually experience this. And this is where in the process of getting the T cells, the body releases a lot of inflammatory cells, and it's like a inflammatory storm, basically. And it can be very serious because it can lead to changes in the way people think. They can be very sick and have low blood pressure and that kind of thing. So again, while there was a lot of cytokine release syndrome, it was mild and people got through it pretty well. And most people were better by about a month after having received this, if they were getting a response and doing well. Only one person had such significant problems that they had that confusion and neurotoxicity. So, kind of just wrapping that up, I just want to say, this was FDA approved in August of this past year. It's probably, it is our first immune-based therapy in a solid tumor, and it's the first T cell therapy for sarcoma. So we're really excited and proud of the hard work that the international community, including our site, did in order to ensure that this got FDA approved. I'm going to switch topics now to a drug called vimseltinib. This goes by the name Ramvimsa. This was actually just approved in February of this year by the FDA for use in what's called tenosynovial giant cell tumor, or TGCT. This has also been known as pigmented villonodular synovitis, or PVNS, and also called giant cell tumor of tendon sheath. It's been called a lot of things over time, and now we pretty much stick to 2 subtypes of TGCT, a local or nodular type and a diffuse type. And that diffuse type includes TGCT. So that's really the specific subtype that this was approved for. And this entity is a cancer, but it generally is only localized. It doesn't tend to spread to other parts of the body, tends to affect younger people. And it's driven to grow by what's called colony stimulating factor 1, which is expressed on by the cells that have gotten damaged. And it's also engages what are called macrophages, and these are the cleanup cells in the body usually. Usually they're there as part of the immune system and to kind of clean up the environment. But they also get affected by this condition and wind up helping the TGCT to grow because they have CSF1 receptors on their surface. And so the crosstalk between these cells causes this to grow. This is also a translocation associated problem, we think, where the chromosomes have swapped information and caused something to grow abnormally. Surgery is generally the treatment of choice for this, but it can have a high recurrence rate, which is why everybody was so interested in trying to find better treatments. It's also because it just really negatively affects people's quality of life. You can see here, this is a picture taken from a TGCT support group website, and it gets inside inside and around the joint, and so it can affect range of motion. It can cause pain. It can affect functional status. So again, the community was really interested in trying to find an alternative treatment, because while we have one agent that's already been approved in this condition called pexidartinib, or Turalio, that particular medication can have a very rare side effect of causing liver damage and sometimes even serious enough to cause death. And so because this is, not something that usually is going to kill someone, we really wanted to find something that was less toxic in order to treat this condition and be able to have people be more functional. And so vimseltinib is also a tyrosine kinase inhibitor, or TKI, but it's more selective. And this was studied in what was called the MOTION trial. It's a multi-center randomized double-blind placebo-controlled study. So in this case, some people got the real drug and some people got something that looked a lot like the drug but wasn't active. And this was also an international study in 13 countries that started enrolling people in 2022. So again, years and years of work that goes into this in order to get to an answer. And people had to, be assessed and found to be eligible, including having at least 2 centimeters of measurable disease. And we had to know that surgical resection wasn't a good idea for these folks. This is an oral pill. It's actually taken twice weekly for 24 weeks, and people who got a good response could continue on even after that first 24 weeks. The response rate in this case was 40%. So still, a lot of folks didn't get a response. And that's why we keep working hard on this. We have actually a study that's going to open in this same area to try to help people because we know not everybody will get a response. And there was still, and I'll show that on the next slide, still some toxicity that we think we might be able to still do better at improving. So, but the good news was that 4 people, or 5% of the 83 people who got the actual drug had a complete response, and 35% had a partial response, which you can see here. So that was really good news. This is information about, again, the seriousness of the side effects. So you can see again here all grades, and then the more serious grades of 3 and 4. Most of it was swelling around the face, but also itching, headache, blood pressure changes. But everyone who got the real drug, in general, would seem to report significant improvements in range of motion, physical function, stiffness, and pain. And so that is why this got FDA approved, even though not everybody responded, because it did help people feel better. And so now it's in our bag of tricks for things that we could do to try to help people with this condition. So lastly, I'm going to try to talk about doxorubicin plus trabectedin. These are 2 chemotherapy drugs that we've already known about and that have been FDA approved. But what was different is that they were used together. This was a study conducted only in France at 20 centers, and it started actually in 2017. Enrolling both people with uterine leiomyosarcoma and soft tissue sarcoma. And they had to have either disease that wasn't resectable or that was already had spread to other parts of the body. And so in this case, people either got doxorubicin alone or the combination. What was really different about this is that the trabectedin was given in a way that's not really done or hasn't traditionally been done in the United States, as a 3-hour infusion instead of the usual 24-hour pump. And this was just published as well. And you see there, 150 people. A good proportion of those were people without uterine leiomyosarcoma, but just the normal soft tissue sarcoma, and equally distributed. And this is, again, one of those survival curves where we're looking at that top line is the people who got the doublet, the 2 things together, versus the blue line. And you can see this is over time. So they followed them from when they first enrolled until they had to stop in order to publish the study. And basically, what you can see is that of those 107 people who passed away on this trial, fewer of them did if they were actually getting the combination. Overall survival at 2 years was 68% in the combination versus about 50% in the doxorubicin group. And so for leiomyosarcoma specifically, this is really important. The other odd thing, though, about this trial is that they allowed surgery after the first 6 cycles. And they don't tell us a whole lot about who got the surgery or whether or not they went back to the maintenance trabectedin that they could get afterwards, after they had their first 6 cycles of doxorubicin. Some of you will know that we usually only give a total of 6 doxorubicin. So about 20% did get surgery, but like I said, we don't know a lot about it yet, who got that. But we think that's why they probably did better, was because they were able, some of those people who couldn't get surgery initially, maybe were able to get it later. And then we also know that there was a lot of toxicity with this regimen as well. And that's the big problem with the regimen. It's hard to tolerate. 23% in the dox trabectedin group did not receive maintenance. And 5 of those people were for progression, but the rest of them were for toxicity. And they had to have dose reduction. So that's just showing you that dose reductions, and then again, those people who stopped taking it because it was hard to do, as opposed to because of progression, because we know fewer people progressed who could continue to receive it and tolerate it. So again, this has really revolutionized, in these last 6 months. These 3 studies are really changing the way we practice. And we're trying to do it safely and effectively for people. So I apologize. I took us right up to the minutes, but hopefully this was interesting and informative.
Thank you so much. I think we had some wonderful questions from the panelists. One was, what's synovial sarcoma? And fortunately, our pathologist will be coming on next, but I can let Dr. Lager speak a bit more to this, along with tying in, since only 14% qualified for the synovial sarcoma afimicell, why target this specific gene if most didn't have it?
Yeah. So synovial sarcoma is one of our many types of sarcoma. So each of these things that I presented was for a different type of sarcoma. Synovial sarcoma for the first one, TGCT for the second, and leiomyosarcoma for the third. It is a form of sarcoma. The reason we targeted that MAGE4 is because at the beginning of the study, we understood that protein was expressed on somewhere between 60 and 80% of synovial sarcomas. So it seemed like a really good target because it's found primarily on the cancer cells, but not on normal cells. The problem is, like I said, in that HLA, finding those 2 things together where they both have that protein, that special protein, and the tissue type is actually harder than we thought in people who are well enough to take the trial and everything when they are, recruited.
The other 2 questions is, why only 1 infusion for the afimicell?
Yeah, that's a great question. So in part, it's because we actually don't know how safe it is to give multiple infusions. And we also don't know, after we give the first one, do those proteins still show up on the cancer cells, or does it actually go away because the cancer that had it, is killed, and then maybe the other cells that are left behind, if there are any, don't have it anymore. So there's a lot we still have to learn about these therapies.
And the last question in the chat was speaking about the doublet treatment. Did that treatment include radiation therapy? I don't think it
No,
did.
in this study, it did not include radiation. Yeah.
These were really nice questions. I want to thank Dr. Lagers for joining. If we could ask you to stay on for another 5 minutes, just in case additional questions come up in the chat. And we look forward to introducing our next speaker. Our next speaker is Dr. Eleanor Chen. She is an associate professor at the University of Washington and Fred Hutch Cancer Center. She is an expert in bone and soft tissue pathology. So all those questions in regard to what is synovial sarcoma, what type of sarcoma do I have, what is a translocation-driven sarcoma, those type of things that Dr. Largos was talking about, you'll be able to understand more after this talk.
I'm going to share my screen here. Cool. Can you see this okay? Just
Yes.
I'm checking. Okay.
Great.
Glad to have this opportunity to tell you about sarcoma pathology. So today I'm going to tell you about some basic concepts in sarcoma pathology, as well as what we do as pathologists. Um, so just to tell you about sarcoma, so what's a sarcoma? It's a cancer that pretty much uh, happens anywhere in the body. So unlike organ-specific cancer types such as cancer, lung cancer, breast cancer, and colon cancer, sarcoma pretty much can occur anywhere in the body. And they most frequently starts out in the connective tissues of the body. So connective tissue is the type of tissue that surrounds other organs, such as muscle and subcutaneous fat or fat in the body. Um, and the most frequent anatomic locations that they happen are the extremities, so the legs and the arms. So, and they also occur in the abdomen and the chest. Um, in general, sarcoma is a rare cancer. Just to give you a sense of how rare they are. Um, for example, I'll just give you a lung cancer, since it's one of the most common cancer types. In 2020, there were about 200,000 cases of lung cancer. But for that year, there were only 13,000 cases of sarcoma. So that's about 7% of all lung cancer cases. So very rare. And unfortunately, of the 13,000 cases of sarcoma, 5,000 of these patients, so it's about 25 to 30% of these patients are expected to die of sarcoma. Just to give you a sense of epidemiology, the age distribution of sarcomas, sarcoma, again, can occur at any age, but it's more common with increasing age. So the median age of patients is about 65. For some sarcoma types, though, there's some predilection for a specific age group. So, for example, rhabdomyosarcoma sarcoma, which is a sarcoma that resembles skeletal muscle, tends to occur in children. Bone sarcomas, such as osteosarcoma and Ewing sarcoma, they tend to occur in children and young adults. In the elderly, we tend to see sarcoma types such as undifferentiated pleomorphic sarcoma, liposarcoma, leiomyosarcoma, and myxofibrosarcoma. So far, there are about 70 sarcoma types that have been described, and they're characterized by their unique genetic profiles and specific histologic appearance. And many of these sarcomas are named based on the type of tissue they resemble. So I'm giving some examples here. Since there are so many sarcoma types, there's only a few that I can give in such a short time. Chondrosarcoma, so chondros comes from the Greek word chondro, which is cartilage. So chondrosarcoma resembles normal cartilage as shown on the right here. And osteosarcoma, so the word osteo comes from the Greek word root osteon, which is bone. So it's a osteosarcoma that is a sarcoma that resembles normal bone, as shown on the right here. And we also have angiosarcoma. So angio or angion in Greek, it means vessels or containers. So angiosarcoma forms these vascular or channels that you see in normal blood vessels. We also have liposarcoma. So lipo is fat. So as you can see here, so liposarcoma forms fat cells that sort of resemble the fat that we see in our body. Just to keep in mind that some sarcomas do not resemble any tissue type. I'm giving two examples here. Gastrointestinal stromal tumor, so it's a sarcoma that is thought to arise from a cell type called interstitial cell of Cajal, which is a cell type or pacemaker cell type that controls the movement of our digestive system. And you can see under the microscope, gastrointestinal stromal tumor doesn't look much like the pacemaker cells of GI tract that we see under the microscope. There's also malignant peripheral nerve sheath tumor, as the name implies. So it's a sarcoma that arises from the nerve, but it doesn't always look like the normal nerve. So it can take on a variety of appearances, as one example shown here. So it doesn't really look like any tissue type. And to make things more complicated, there are some sarcomas that have overlapping morphologic features, so they look alike under the microscope, especially the sarcoma types that have these small round cell appearance. I'm giving you two examples here. So Ewing sarcoma and alveolar rhabdomyosarcoma. So there are two sarcoma types that look alike, but have very different disease biology and genetic alterations. And there are also sarcoma types that mimic other cancer types. Again, especially the sarcomas that have these round cell appearance under the microscope. I'm giving Ewing sarcoma as an example again. It's a round cell tumor. It can also look like lymphoma, which is almost always composed of round cells. And also there's specific type of carcinoma that can also have round cell appearance, particularly small cell carcinoma, which we see frequently occurring in the lung. I just want to touch on angiosarcoma. There's a specific type of angiosarcoma, the epithelioid variant of angiosarcoma. So it can be scary. So they actually don't form, a lot of times they don't form vessels or channels that look like blood vessels. Instead, they can mimic another cancer type, the squamous cell carcinoma, which tends to occur in the skin, but you can also see this cancer type in the lung. So what do we do with the sarcomas that really we cannot tell what they are under the microscope and to exclude other mimics? So we rely on additional tests, ancillary tests that can help us figure out what they are. And I've listed three major methods here that we use frequently in the clinical pathology lab. Immunohistochemistry is the most common method that we use in the lab. It's a laboratory technique where we use antibodies that would recognize specific protein or marker that's present in a specific tumor type. So for example, the presence of brown staining, as in this example here, means the tumor has that marker that we're looking for. Thereby, we can say what type of tumor that is. There's also fluorescence in situ hybridization or FISH. So it's a genetic technique where we label genetic materials or specific regions in the DNA with fluorescent signals. So a cell will glow if it has a specific type of genetic alteration. For example, gene amplification, which I will touch on in a little bit, and gene translocation, that's where when two regions of chromosome come together to make a fusion gene that defines a sarcoma type. We also frequently rely on next generation sequencing, which is a molecular technology that allows us to detect specific mutations or DNA alterations that are present in a tumor sample. I just want to give you a specific example of FISH that we frequently do on liposarcoma, which is a sarcoma that resembles fat, and it's one of the most common sarcoma types that we see in adult patients. So genetically, it's characterized by amplification of a gene called MDM2. So when a gene is amplified, that means there's lots and lots of copies of this type of DNA in a tumor. So liposarcoma is characterized by amplification of MDM2. So if we label this region with a fluorescent signal, so if it's indeed a liposarcoma that we're looking at, the tumor should have lots and lots of these MDM2 signals in cells, in tumor cells, compared to normal tissue. So it's shown here. Next, I kind of want to just give you a sense of how we predict prognosis in sarcomas. So one way we do it is to grade sarcoma. So grading sarcoma help us predict biological behavior of the sarcoma. So a high-grade sarcoma shows a more aggressive clinical behavior compared to low-grade sarcoma. The way we grade sarcomas in pathology is based on three major criteria. Shown here, tissue differentiation, which is a criteria by which we assess whether how closely the sarcoma resembles a normal tissue type. There's also mitosis or cell division, and necrosis or cell death or the amount of dying tumor. And each category here can be scored up to 3 points. And then at the end, we add up all the points. So a high-grade sarcoma has the most number of points. So in other words, a high-grade sarcoma doesn't really much resemble any tissue type, and it has lots and lots of cell divisions, and it also has lots of necrosis or dying tumor areas. Just to give you a sense of how a low-grade sarcoma and high-grade sarcoma look like under the microscope. So I'm giving you two examples. So on the left is a low-grade fibromyxoid sarcoma, and you can see it's characterized by these really uniform spindle-shaped cells, and they're very uniform in size and look pretty much really bland. And on the right, it's a high-grade leiomyosarcoma, and you can see there's a huge contrast in appearance to low-grade sarcoma. The tumor cells have these enlarged nuclei, and they're very irregularly in shape. And the tumor cells are really crowded, and they'll grow on top of each other. So that's the low-grade and high-grade sarcoma. This is sort of an exercise for you to think about and see if you can tell whether these tumors are high grade and low grade. I'll give you 3 seconds to think about it since I don't have a lot of time. Okay. So I just want to review answers here quickly. So hopefully you got them right. So the left is a high-grade sarcoma, and it has shown here as a cell dividing, and you can see the cells are enlarged and very irregularly in shape. And on the right is a low-grade myxofibrous sarcoma, and you can see the cells are pretty much uniform in shape and pretty small and widely spaced. And so that was grading, but there are always exceptions to the rule. So there are some sarcoma types that we don't assign a grade just because they already have their own unique biological behaviors. There are some sarcoma types that have indolent behavior, but they metastasize late. So some examples are alveolar soft part sarcoma, angiomatous fibrohistiocytic tumor, and ossified fibromyxoid tumor. So these tumors, they grow slowly, but they eventually metastasize. And alveolar soft part sarcoma, for example, can metastasize 20 years after they occur. There are some sarcoma types that are automatically aggressive, so we don't need to grade them. For example, epithelial sarcoma, pleomorphic liposarcoma, Ewing sarcoma, and rhabdomyosarcoma. Staging of sarcoma is another way that we use to sort of assess prognosis of sarcomas. It's a process by which we determine the extent of sarcoma or tumor burden in the body. The most common staging system that we use in pathology is the TNM system. T is tumor size and location, and N is the number of lymph nodes with cancer, and M is metastasis or distant spread of cancer. Again, the higher the stage, the worse the prognosis is for a sarcoma. Finally, I just want to tell you about what we do as pathologists. We pathologists specialize in evaluating tissue samples from patients. So when a surgery, resection, or biopsy specimen comes into the pathology lab, we perform what's called gross evaluation of the specimen. So we look at the specimen with naked eye, and we determine we document and measure the tumor to characterize various features of the tumor. So for example, we measure the tumor size, and once we cut into it, we describe the color and texture of the tumor. And I mentioned necrosis before, which we tend to see in higher grade sarcoma. We can also see area of necrosis when we cut it open, the gross specimen. Another thing we do when we look at a surgical specimen is to evaluate distance to surgical margin. You will hear more about surgical margins later, but for us, it's important to determine tumor to surgical margin. Surgical margin is normal tissue around the tumor that gets removed during surgery. And for us, we ink the edge of the surgical margin with each with a different color. So that allows us to tell them apart under the microscope, which margin is what. And the colors also are good benchmarks for us to measure the tumor to each margin. So ideally, you want the tumor to be away from the surgical margin. So if the surgical margins are free of tumor, that means the cancer is completely removed and there's nothing left behind in the patient's body. So that's good news. And if the patient was treated with chemotherapy or radiation prior to surgery, we also will want to assess treatment response or how tumor responds to treatment in a specimen. So we extensively sample the tumor. So for example, in a bone sarcoma, we sample the complete cross-section or a slab of a tumor, and each of these sections gets processed, and we look at all the sections under the microscope and come up with the percentage of tumor cells that have responded to treatment. Just to summarize what we do as a pathologist, so we interpret biopsy and surgical resection samples to determine whether the tumor is benign or cancerous. And then we issue a final pathology report that includes a final diagnosis, as well as the various information about the tumor, such as the sarcoma type, grade, other features such as mitosis, necrosis, stage, and also we include results of additional testing if we did them. And we work with other members of the clinical care team to discuss next steps in clinical management. And this occurs mostly in a setting of tumor boards or tumor conferences. And some of the pathologists, like me, are research scientists. We try to translate laboratory discoveries to clinical applications. So that's all I need. That's all I have. Just to quickly summarize what I told you today. Sarcoma is a rare cancer that can occur anywhere in the body. Some sarcoma types resemble certain tissue types, and some do need additional tests to confirm their identity. And grading and staging can help predict clinical course of the disease. And finally, we pathologists help determine the final diagnosis, whether the tumor is entirely removed, and then we give information that hopefully could help guide the next steps in clinical management. Okay, that's all I have. I'm happy to take any questions.
Thank you, Dr. Chen. That was excellent. We do have a couple questions in the chat that I can read off to you here. So both are related to rhabdomyosarcoma. So the first is with rhabdomyosarcoma being able to affect both the soft tissue and bone, are the cells the same or different given that they're different environments? And then a follow-up question of that is that if they do involve the bone, what's the probability it will enter the marrow?
So it doesn't matter where the rhabdomyosarcoma is occurring. So the histology appearance would be similar. Um, just keep in mind, though, in general, like I said before, all the sarcoma types pretty much can occur anywhere in the body. The same thing holds true for rhabdomyosarcoma. So it doesn't matter where they occur. Histologically, they will still look very much alike because that's what defines the sarcoma type. In bone, so rhabdomyosarcoma, as in a lot of sarcoma types, when they occur in bone, they also involve the marrow. So, and although that's an interesting fact about rhabdomyosarcoma, unlike a lot of sarcoma types, rhabdomyosarcoma also tend to metastasize to lymph nodes, especially the alveolar subtype of rhabdomyosarcoma.
Got it. And then there was another question that maybe just a brief response on, but can you again just quickly touch again on the difference between stage and grade, just to confirm?
So grade is the intrinsic characteristic of tumor. So like when we look at sarcoma, whether it's low grade or high grade, stage is sort of an overall like where the tumor is, whether it has metastasized to other sites, kind of a more generic overall location metastasis, clinical prognostic factors. As gray as more of an intrinsic characteristics of a tumor.
Great, thank you. That's actually a great question. I'll speak to it a bit in my talk as well. But I am actually the next speaker, and my name again is Jeremy Sharib. I'm one of the surgical oncologists. Thank you again, Dr. Chen. I'm just going to try to pull up my screen here, so hopefully you guys can all see. Should be able to see that.
Yes.
All right, great. So like I said, I'm one of the surgical oncologists. I mainly take care of abdominal sarcomas or retroperitoneal. And one of the questions that we often get is how we think about kind of operative planning and resectability for these. So I wanted to try to give a little bit of a primer with a lot of pictures and examples of defining resectability for retroperitoneal sarcoma. The overall kind of plan that I have for my talk is just to show you the challenges of retroperitoneal sarcoma in the various ways that it can present. I think it's really important for me to communicate kind of the operative goals for any surgeon when we're doing surgery for abdominal or retroperitoneal sarcoma. A lot of the questions on operability go to critical versus non-critical structures, so I'll touch on that a little bit. And then most of the talk is going to be dedicated to primary disease, so the first time that the sarcoma kind of presents. But We'll tell a little bit about the differences when the disease is recurrent, as there are different thought process that goes through there. And then to link it to some of my other colleagues who are giving presentations today, I wanted to bring up preoperative therapy and how that may impact operability as well. So to start off with a little bit of a quote I think is pertinent for the rest of the talk. Retroperitoneal sarcoma, it's akin to a fingerprint. Each tumor is unique. By virtue, no two operations are going to be identical. And I think you'll see that in the next couple slides. So these can be challenging for a number of different reasons, both kind of size and then also location. So for instance, this is an 80-year-old woman who had presented to me with new onset bloating, a palpable mass, and some edema in her legs. This is a CT scan that on both views, you don't have to really know how to read a CT scan that well to see that if this outline that I'm drawing here is the abdominal cavity, this large gray circle is actually the tumor. Her kidney is kind of floating around in the middle. And on both views, you just see that it takes up a lot of room. So clearly just kind of challenging from that perspective. As I go through these, we talked about sarcomas really being vast in their um, their different subtypes. In the abdomen, it's a little bit easier for us. There's approximately 5 that really make up most of the different tumors that we see. So the most common being liposarcoma, and that can be what's called well diff, which is kind of a lower grade liposarcoma, or D diff, which is a higher grade liposarcoma. But those themselves make up 2/3 of the cases in the abdomen. The next most common is something called leiomyosarcoma, which is generally of the soft tissue and smooth muscle from, for instance, the blood vessels. This is another kind of different location of tumor in the middle of the abdomen here. You can see it's less big, if you've looked at a CT scan before, you might notice that it's by some really big blood vessels. So we'll talk about why that may be a problem later on. Totally different area. This is now deeper in the pelvis. This is the pelvic bone kind of flanking this tumor. You can see that again, it's filling up a really large portion of the pelvis in this case. From the side view, it almost looks like there's a pregnancy in the pelvis from how large the tumor is. We can see, some of the pelvic organs like the bladder being kind of smushed here. This is a different subtype called UPS, or it's a high grade kind of otherwise uncharacterized sarcoma that Dr. Chen had mentioned towards the end of her talk, but one of the major subtypes we see. And then finally, a totally different area. We'll touch a bit on why this was a challenging tumor later, but this is called an NPNST, which is another subtype that we see in the retroperitoneum. One of you probably see from that series of photos that one of the challenges that we have when thinking about retroperitoneal sarcomas is that they can really arise in any part of the abdomen, and each location has its own set of issues and challenges that come with it. So I'll try to go through some of them here. But first, as I mentioned, I think knowing the overall goal of the operation is really important because it helps kind of determine how the challenges that we encounter kind of come about and how we work to get beyond them. So the 3 things that we really need to think about when deciding on an operation for a retroperitoneal sarcoma are you heard a little bit about grade and stage in the last talk. Grade is about the tumor itself, as you heard. So an operation can be done on a low-grade tumor or a high-grade tumor. But stage is important because we typically wouldn't operate, at least for the first, the early treatment management for something that had disease elsewhere in the body. So there really shouldn't be distant disease beyond that primary tumor. And then when thinking about the primary tumor itself, the main goal for us is always en bloc removal of the entire tumor, and that might include any involved organs or adjacent organs if those are needed to fully resect the tumor. En bloc means it comes out in one piece, and usually if the organs are involved, that if any organ is involved, it means with that organ as well. you don't want to be removing these tumors, what we call piecemeal or in multiple pieces, if possible. And then in terms of margins, in the abdomen, it's a little unique. This is often a hard concept to understand, but we aim for complete tumor removal with a grossly negative margin. So that means we remove all the tumor, you don't see any tumor left behind. It doesn't show up on a CT scan either. But related to some of the kind of anatomic confines of the abdomen, and also where these tumors arise from, kind of in the retroperitoneal fat, for instance, the tumor itself doesn't always allow for a fully microscopically negative margin. But it turns out that when we think about prognostically, if we actually separate out tumors that were removed in their entirety with either a complete negative margin or a microscopically positive margin, perhaps, versus those that are removed with gross tumor left behind, that's really the main difference in terms of recurrence and in terms of survival. And so, again, complete resection is the goal. So, in thinking about that, going back to kind of how we differentiate each area of the abdomen, again, I'll look at the next slide here, which shows kind of the organs of both the retroperitoneum, so the very far back, as well as the next kind of layer of organs that are set in front of them. And we can see that the tumors very often grow in kind of the fatty area around the kidneys or in the areas around the blood vessels. And so I showed a pie chart on the last slide that basically says a lot of these operations do involve removal of one or more organs with them just because of the way that abdominal sarcomas grow. The most common is the kidneys, followed by the colon. And that's because these tumors tend to grow kind of on top of the kidney and right behind the colon. And so the margin on either side is really the most common organ that's going to be touching these tumors. And those are the ones that are less critical to sacrifice. When I go through each kind of quadrant of the abdomen a little bit more in detail here, we'll see that, but generally aren't going to be things that would prevent an operation from being possible. But if we go more specifically through the abdomen, so first in the right upper quadrant, again, in thinking about primary disease, so tumor is the first kind of tumor that's grown. There is limited data on what's an agreed upon criteria for unresectability for RP sarcoma. And in probably the largest series addressing this topic, coming from the Italian group, which is actually a very large European sarcoma center, only about 11% of patients were deemed unresectable for primary RP sarcoma. And looking back at our series for the last 3 or so years since I've been here at Fred Hutch, our numbers are just under 10%, so kind of in line with that, but again, just relatively low. But in their series from the Italian series that I mentioned, in the right upper quadrant, there were a potential couple hard stops for resection. And those are mainly related to the vascular or blood flow into and out of the liver. So the first thing that they reference is if there's portal vein involvement, so this big vein kind of going into the liver, that is a relative contraindication to doing an operation. That's a relative inoperable area. And that's the same for the veins that come out of the liver. So for instance, in this particular case, this is a really large tumor. We talked about it required removal of the kidney and the colon, but it kind of pushed up all these portal veins. And so this came out without really any worry of the vascular inflow to the liver. Whereas in contrast, this is a different picture, but we can see that the tumor itself is much smaller, takes up a much smaller area, but it's very kind of jammed into this really critical real estate. So the portal vein we see has a very long segment of involvement here. On the other picture, we can see in a different view that the hepatic vein, the outflow from the liver, also has some involvement. And so this is kind of one of those rare cases where we actually deem this unresectable because of involvement of both of those blood vessels, and so the risk would be too high for conducting this surgery. Thinking about just a slightly different area of the abdomen, the second picture I showed earlier, again, is kind of central. And that was a big leiomyosarcoma, so a large blood vessel tumor. So we actually see this arises from one of the blood vessels called the inferior vena cava. But the kind of the key part of this particular tumor actually refers more to one of the areas where when we try to conceptualize the concept, I guess, of unresectable, again, I mentioned it's not standard, but when a group of surgeons in our international working group called TARPSWIG, we're actually given a survey about, what makes a tumor unresectable for you. It turned out that the most common answer was the involvement of two major blood vessels that come off of the aorta. The first being what's called the superior mesenteric artery. Hopefully you can see my pointer. I'm pointing to it here on the right-hand side of the screen. And this blood vessel supplies all of the small intestine and a part of the colon. So if you had to remove a tumor that was kind of at its origin, the risk would be to devascularize, lose blood supply to the small intestine, which you really can't live without the small intestine. So that's a major issue. And the second one is just a little bit higher. There's something called the celiac trunk. That's another big blood vessel that comes off the aorta. And this supplies the liver, the pancreas, the spleen, and the stomach, all kind of shown here in various cut ways. So this is another area where tumors that really involve that blood vessel can be problematic. The other thing right in that vicinity is this first part of the small intestine. It's called the duodenum, and it kind of wraps around the pancreas. And so that area also contains that structure, which happens to be something that's challenging to do an operation on, but not, can still be done, but makes an operation harder. In this picture, this tumor, I mentioned it comes from the vein, but it also really it comes close to that superior mesenteric artery. So the key here is that it doesn't wrap itself all the way around. It just kind of is touching it on one side of it. So this tumor actually was resectable because we were able to separate the artery from the tumor itself. There's also a little bit of a tongue that goes up towards the celiac, but if this were wrapped further around that artery, it would not have been resectable. But in this case, this is a good example of difficult, but still doable. Just moving on to the lower quadrants, turns out that kind of mentioned there's less non-expendable organs there. So that's lucky because a lot of the tumors actually do arise lower down in the abdomen. We talked about the kidneys being the most commonly removed organ as part of these operations. And the good thing is that we're lucky to have two kidneys. In general, when one is removed, the other can pick up the slack. The overall kidney function is minimally impaired or even normal. And similarly, the right or left colon, which again sit kind of just one layer in front of that, can also either side or actually even the whole colon can be removed without a dramatic difference to lifestyle. But there is a relative contraindication if a tumor starts on one side and extends over to the other and involves both kidneys, then you may have to remove both the kidneys to get a negative margin for that tumor. And that's a relative problem because you would make the person have renal failure, which there are artificial ways to kind of deal with that, but it's really you have to question if that's the right thing to do in that scenario. And then the last thing kind of in the lower abdomen is that there is also the potential for nerve or spinal involvement. And so in this picture, we see a tumor kind of along the left side of the spine that extends into what's called the neural foramina, where the nerves are coming out of the spine into the retroperitoneum. And to some, this would be unresectable, but we're lucky here at Fred Hutch to have a multidisciplinary team, which includes services such as spine surgery and orthopedics. And in particular, in this tumor, We were able to remove it because our spine team was able to first stabilize the spine in kind of the first stage of an operation, make a partial cut, and then we came from the abdominal side, removed the tumor, and kind of actually um, uh, carved out a portion of the spinal column here to be able to remove that. So very lucky to be in a place where we're able to do things like that. Um, Finally, while I mentioned the pelvis is a complex anatomy kind of in a small space. A lot of the things, including the rectum that you see here, as well as the bladder, which sits up front, if need be, can be kind of diverted to be able to remove tumors that are filling the pelvis. In this particular case, for instance, this patient had to have a colostomy to remove this tumor, but the bladder was actually spared. So sometimes just freeing up some of that space is possible. So just in the last couple minutes, everything that you've seen so far is really related again to the primary tumor. So the first time we're seeing the tumor, the first operation a patient's having, it turns out that these tumors, they even when surgery is done well, when additional treatment is performed, they do tend to come back, and a lot of times they come back in the abdomen in what we call local recurrence. Um, these are harder, and so a lot of the calculus that we have for resectability does change. Part of the reason is I mentioned there's a few most common subtypes that we deal with, and each one has its own kind of characteristics in terms of how they'll interact with the various tissues that they're touching. And so there's a lot of expectation that we can have when looking at a CT scan about how the operation may go. Unfortunately, for recurrent tumors, those kind of rules or adherence to those rules is somewhat changed. And so when we do have apparent involvement of organs or vascular structures, the expectation really has to be that we may need to sacrifice those in order to get the tumor out with those negative margins. And so the complication rate can go up high for those surgeries. And we have to really think harder about, is it the right thing for that person? And generally, people have been through more by a second operation. So are they physically fit to undergo the surgery? The second thing is for recurrent tumors, we often see them come back not just in one place, but in multiple. And so there's a biology question about doing a removal. So even though it might be technically possible, as the fact that there's multifocal or multiple tumors, does that mean that we're really kind of behind the disease itself, and really that surgery may not get us back ahead of the disease, and so it may not be the right thing to do from the biologic perspective. And then I mentioned that surgery on recurrent tumors tends to have more complications. So we have to really just think about the person's ability to undergo the operation. And then finally, when we think about sarcoma, there are some patients who undergo multiple operations, more than just one or two, and even beyond that. And every time that disease comes back, the interval between the last time they had a intervention and now may be decreasing. And so again, that gets to the question of biology for these tumors. So lastly, I just wanted to touch on two kind of concepts for preoperative therapy. And so again, surgery is obviously not the only treatment for sarcoma. We're hearing a lot about medical therapies as well as radiation as well. And in some cases, we've thought that, these tumors, they come back, they come back where they start. Sometimes they come back in other places. Is it possible to use some of these other therapies with surgery to be able to address that? And so on the left, this is a study that was a preoperative, so prior to surgery radiation study, where it turned out that for all comers in the abdomen, there wasn't a significant difference between those people who got preoperative radiation and those who didn't. But when we looked at the lower grade tumors, which are actually more likely to come back in the area where they start, there was a signal there. And so, for some of these, we often think that we know that the margin on these tumors is going to be challenging. So radiating them before kind of treating the margin, treating the tumor might prevent those recurrences because it just kind of allows the whole field to be treated. On the right-hand side, this is an ongoing study that kind of on the flip side for those high-grade tumors, we know they're more likely to come back in other places. They also may be kind of infiltrative in the beginning. So can perhaps chemotherapy be used to both prevent recurrence to the distant sites of the body, but also in some cases we might even get shrinking of the tumor and might facilitate an easier operation. So that's an ongoing question as well. So in conclusion, as I mentioned, retroperitoneal sarcomas, resection aims for complete removal of the tumor along with any adjacent or involved organs. Resectability itself is not well defined, but largely depends on proximity to critical structures, histology of the tumor, and then patient factors. Recurrent disease is more challenging, and therefore resectability may be more limited. And preoperative therapies in the primary and the recurrent setting may convert some borderline tumors or inoperable disease to resectable. So I want to thank you. I'm going to stop the share and look at the chat here. So thank you again. Let's see here. It looks like there is one question in the chat, so I'll read it out loud so others. I don't think the audience can see this. It says, I'm curious if you know you won't be able to get clear margins, is it better to remove the bulk without clear margins or just treat with radiation and then possibly go remove it after it shrinks? I also understand it depends on where it's located, but more so speaking to the extremities or the abdomen. So I can address the abdominal part. Dr. Roberts will speak about extremity sarcoma in just a moment, but I would say in this scenario where maybe the margins are expected to be positive, if that's truly the case, regardless of aggressive resection, then you really have to kind of think if surgery is the right thing to do in general, just because again, it doesn't accomplish that first goal of achieving a complete resection. But the part about the radiation is really pertinent, where as I mentioned in the last slide, if there's a at-risk margin and we know that going in, we will very frequently use radiation to be able to treat that so that even if it's close or microscopically positive, we feel that the local recurrence risk is at least mitigated or decreased to some extent by treating the periphery of the tumor where that margin might be positive. So with that, I will stop talking. I want to introduce Dr. Roberts. Dr. Jesse Roberts is an assistant professor of orthopedic surgery at UW Medical Center and Fred Hutch Cancer Center, as well as Seattle Children's Hospital. So he really wears a lot of hats for the sarcoma program. He is an orthopedic oncologist who specializes in bone and extremity sarcomas, and he's here to speak today about orthopedic surgery again for bone and soft tissue sarcomas. So without further ado, thank you, Jesse.
Thank you for the introduction, and thank you everyone for attending today. I hope this is valuable information for everyone, and it is nice to interact even though it's virtual. So I'll be covering a few topics, sort of emerging technologies in orthopedic surgery and sarcoma. It's nice to already have the context of some medical oncology, some pathology, and some surgery. As we already get into this talk, I'll try to be as quick as possible and keep us on schedule as much as we can. Make sure I'm advancing. Is the sharing working well? Everyone seeing the screen nicely?
We can. Thanks.
All right. So the term sarcoma covers a very large set of connective tissue cancers with unique histological appearances, anatomic distribution, biological behavior, and genetic and molecular drivers. This is you've already seen a bit of that heterogeneity, and that's why it takes such a very large team to care for this set of diseases. So the treatment of sarcoma relies on a very large and dynamic team, starting with our patients, their families, friends, primary care providers, followed by the team of specialists at specialty care centers. This is just a brief overview of who is part of that team for us: our medical oncologists, radiation oncologists, surgical oncologists, orthopedic oncologists, our bone and soft tissue pathologists, musculoskeletal radiologists, plastic surgeons, vascular surgeons, anesthesiologists, physical medicine, rehabilitation specialists, physical therapists, occupational therapists, and the list continues. But it's just important that sarcoma care requires all of these people to do it as well as we possibly can. The role of orthopedic surgeons in the treatment of sarcoma. The traditional pillars for treatment includes medications, and Dr. Loggers shared very well. Medication does not just mean chemotherapy. There's a wide variety of new treatment options that are coming online, including immunotherapies, targeted cellular therapies, but medications for systemic control, meaning treating the tumor wherever it may be in the body. And then the modalities of radiation therapy and surgery are largely about local control, removing the tumor where it originated. Orthopedic surgery focuses on the local control of sarcomas in the extremity, the pelvis, and the spine. And our goal in the surgical treatment of sarcomas is to remove the tumor in a way that has as low a risk of possible of ever coming back, and to do so in a way that allows the patient to function as well as possible for the life that they want to live after treatment. This is not an emerging technology, but I will never pass up any opportunity to give a presentation on the topic of sarcoma without mentioning this. This is a quote from William Enneking, who's one of the founding fathers of orthopedic sarcoma surgery. And his quote is, as it was told to me, is, "It is never a hazard to know the diagnosis." And this is to point out that benign soft tissue masses are incredibly common. Malignant soft tissue masses such as sarcomas are incredibly rare. So making the diagnosis is the first step to most appropriate treatment. So having clear guidelines on when to obtain imaging, when to biopsy, and when to refer to centers is essential to keep patients from having inadvertent positive margin surgeries or improper biopsies that negatively impact our ability to cure sarcomas, and to do so without maintaining limb function. So the three principles that I try to pass around are: anything that is greater than 3 centimeters or deep to the fascia needs an MRI with and without contrast. And a biopsy should be performed unless there are clear and definitive features that are diagnostic of a known benign entity, and that the planning and biopsy should be done by the treating center or treating surgeon who's going to ultimately manage the disease. So with that, I want to transition to a little bit more on the meat of this presentation, talking about some of the emerging technologies within orthopedic oncology surgery. And first, briefly, that's just some advancement of our relatively routine resection and reconstruction techniques, and then touching briefly on intraoperative navigation, custom cutting guides, and custom implants, fluorescence-guided surgery, and osseointegration and myoelectric prostheses. This is just a sampling, and again, focusing on the orthopedic components of care as opposed to sarcoma care overall. So first, improvements in limb salvage surgery and reconstruction. This emphasizes the importance of multidisciplinary care. Dr. Sharib pointed out that we have the luxury of having a multitude of surgical specialties who we collaborate with, and that's essential for being able to offer the types of reconstructions that are necessary to obtain negative margins and to achieve reconstructions that allow a good quality of life once that is done. So this is a MRI demonstrating a sarcoma about the medial elbow. This is the distal humerus. This is the sarcoma. This is a recently retired patient with a passion for knitting and crafting, with this sarcoma diagnosed in her dominant hand. You can see that the sarcoma completely encases the ulnar nerve, involves the ulnar collateral ligament, and a large portion of the skin overlying. So resection of this necessitated removal of a large portion of skin, resection of the ulnar nerve, and resection of the collateral ligaments that provide stability to the elbow joint. So how are we able to do this and offer the patient a good oncologic and functional outcome? So first step is obtaining a negative margin. That's a necessity. One of the ways that we do that is doing a staged resection and reconstruction. So that's doing those on separate surgical days. So our resection happens, we place a temporary dressing, we send the tissue to our pathologists, and wait to do the reconstruction until we know that we have a definitively negative margin. That's in an effort to make sure, again, that we get a negative margin with low risk of recurrence. So then how do we manage having removed, essential structures for a functioning arm? So we borrow something from our sports surgery colleagues. An ulnar collateral ligament reconstruction is actually known as a Tommy John surgery. So that is something that our sports surgeons do all the time for throwing athletes. So this is, not a sarcoma surgery technique, but it's something that happens very commonly in athletes. For any 49ers fans out there, it's what Brock Purdy had. It is what many football and baseball athletes have to reconstruct ligamentous injuries. So it's a borrowed technique from other benign orthopedic practice. Then we use an intralateral thigh flap. That's a free flap moving skin muscle with its blood supply from the thigh in order to provide soft tissue coverage. And you can see on this clinical photograph that this tissue right here is the thigh skin that's been translated to that location and tied into a new blood supply. Most importantly for this patient, it involves a cabled nerve reconstruction. So they take donor nerve from the patient's lower leg, they cable it, meaning running it back and forth multiple times to reconstruct the segment of nerve that was removed, as well as doing nerve transfers distal down the arm to restore motor function. And this is in conjunction with our multiple plastic surgeons who help achieve this type of reconstruction. And obviously this is not possible in all patients. This requires a relatively small length of defect for the nerve. But this is an example of where this was highly successful. So this is just pushing our reconstructive options in order to obtain functional outcomes in negative margin resections. So intraoperative navigation is another technology that we're able to use to help push for better margins and better function. That, to me, is the theme of how we improve orthopedic surgery for sarcoma. So intraoperative navigation uses 3D images such as a CT scan and optical scanning cameras to provide screen-based images most commonly that presents the patient's anatomy in real time, as well as the position of our navigated instruments to allow for precise cuts and implant positioning. Up top, you see the screen-based navigation. So that's projected on a screen in the room where we see the patient's anatomy in real time, reference to our instruments so we know exactly where our instruments are to make precise cuts. And what you see on that lower image is actually a new form of navigation where we use an augmented reality, such as a Microsoft HoloLens, and that allows the navigated information to be projected to our screen and actually overlay the patient's anatomy to allow us to have a different way of displaying that navigation information. And those are both technologies that we're using now in select circumstances. So, I think the medical oncologists often set the standard for determining, true randomized controlled trials to guide best practices. Within surgery, this is much more challenging. We end up with much smaller case series, but there's some data to show, though it remains very controversial, that we are able to improve definitely bony margins, but not soft tissue margins with these types of augmented surgeries. So this is an example of a patient with a pelvic sarcoma of the soft tissue invading bone. Using intraoperative navigation, we're able to make a planned bony cut that allows us to preserve essential structures, in this case, the left hip joint, to allow for improved function with a negative margin resection. Next technology that we're using now is custom cutting guides. So this is a very similar technology in that it allows us to make precise bone cuts. What makes it different is that it also allows us to design 3D custom implants or custom cutting guides to provide allograft in a way that makes the reconstruction extremely precise, allowing for more durable ingrowth and longevity of these implants. So, there's certainly much to be shown in the overall long-term effects on recurrence and survival, but certainly there's a role in obtaining negative margins for pelvic bony resections. Whether to use navigation or whether to use custom guides depends largely on whether you're using implants or not. And most often we will use guides when it comes to implants. So this is a case of a cement truck driver, father of 4 with a pelvic bone tumor. This is an example of what we're able to do with our planning based on CT scan and MRI, creating a custom guide, designing a custom implant. And this is what that looks like after surgery. This patient's 7 months out, ambulating independently, almost as if this was a simple hip replacement with no evidence of local recurrence. Moving on to something that is more in the developmental phase, not something that we're using clinically yet. I guess just back to the 3D printing and guides. UW is in the process of developing a Center for Computer and Additive Manufacturing within the School of Medicine. That's going to put us at the forefront of this field, being able to do much of what's being done outside with industry in-house with our ability to print 3D models for patient education as well as for intraoperative use in surgery. And that should be coming online in 2026. So back to fluorescence-guided surgery. We've talked about the importance of margin, and as of now, the ways that we guide our margins for resection is all based on preoperative imaging. So being able to see margins real time in surgery is in a lot of ways a holy grail that will allow us to augment our ability to obtain negative margins while preserving normal structures. So there are many ways that this is attempting to be done, including ICG and fluorescence, near-infrared imaging, LiDAR fluorescence, and photoacoustic imaging. All of these have benefits and limitations and are being studied in different settings. But in general, the ability to identify using molecular tags the cancer tissue in comparison to the normal tissue remains a challenge, as well as the transparency of native tissues and being able to detect that tumor through blood and other tissues that are realistically present in surgery remain limitations to this, but it is being clinically implemented in other oncology fields. So lastly, touching on osseointegration and myoelectric prostheses, there are times where oncologic cure and limb salvage are not compatible. Amputations can offer radical margin surgeries with minimal risk of local recurrence. And although traditional amputations in lower limb for some patients can offer excellent function and quality of life, this is not true for all patients, particularly for upper limb amputations and above knee amputations. So this is certainly an area that offers room for improvement. So what you're seeing on the left is an osseointegrated implant with a socket that relies outside the skin. And then over here, demonstration of how myoelectric signal can be gathered from native nerves and muscles to drive a prosthesis. So this is, again, something that is in clinical practice, but certainly has much room to grow within the field. It is a place that, there is early research going on at our institution to push this forward, though it's not standard of practice. So in conclusion, our ability to cure sarcoma and achieve long-term remission lags behind many other oncologic specialties. The most impactful innovations will likely come from novel systemic targeted therapies, immunotherapies, and cellular therapies that are dependent on better understanding of the genetics, biology that drive sarcomagenesis, metastasis, and the interplay with our body's innate defense mechanisms. Surgery will continue to play a role in sarcoma care, and surgical innovation should drive to provide surgeries that decrease the possibility of local recurrence, ensure patients' function, as well as the possibility for tumor resection, and minimize the impact and odds of surgical complications. So tried to catch up a little bit, but we're still slightly behind, so I want to leave some time for questions if there are any. I'm not seeing any, so I guess we proceed to our break and try and rejoin.
Yeah, sorry, Dr. Roberts. We were just giving a second for any questions to trickle in. It actually doesn't look like there were any, but very I thought very captivating talk. So as everyone's probably aware, we are a few minutes over. We're cutting into the break. I think we'll still try to take um, a 5 minute break. So it's 10:40 now. Maybe we can reconvene at 10:45 to get started with the second set of talks. Hopefully, we'll still be able to finish on time, but we'll start back up in about 5 minutes or so. Thanks so much.
Thank you so much, and welcome to our second half of our patient education session. I would definitely encourage everyone to stay on for the entire length if possible, or to come back and watch it virtually afterwards, particularly also in regard to our two sponsors, the Northwest Sarcoma Foundation, as well as Sarcoma Foundation for America, who are pivotal in terms of supporting you as patients with patient grants, different supportive opportunities for both yourself and caregivers, as well as for the physicians, investigators, and other personnel in terms of advancing our missions as well. Next, I have a lot of pleasure to introduce Dr. Michael Folkert, who joined our practice in fall of this year. He is a full professor in the Department of Radiation Oncology at the University of Washington and Fred Hutch Cancer Center, and the director of our Brachytherapy and our neutron cyclotron program to speak about radiation oncology today.
Thank you very much. So I'll try to share my screen. Let's see. Okay. All right. Is the sound and the slides coming through okay?
Looks great.
Excellent. Thank you very much. All right. So thank you again for that introduction, and thank all of the attendees for joining us today. And I'll be talking about some advances in brachytherapy, intraoperative radiation therapy, and adaptive radiation therapy in the management of sarcoma. These are my disclosures. The only relevant one is that I had some travel reimbursement from Varian, which makes some of the tools that we'll be talking about during this talk. And I'll be shortening intraoperative radiation therapy. I'll be calling IORT, and adaptive radiation therapy I'll be calling ARC, just to make things a little bit simpler. And first off, so what is brachytherapy? So brachytherapy is a technique where you place radiation sources either very close or actually within a target. Teletherapy, beam radiation is how we often treat patients as well, but those are beams coming from outside. Brachytherapy is from inside. And brachytherapy relies on some math in order to be most effective. So a radiation source emits radiation, and it falls off by the square of the distance. So that's the inverse square law. So you see this slope right here. And basically what that means is that if you're right next to the source, it's getting an enormous amount of dose. But once you get just a few millimeters to centimeters away, it falls off very rapidly. So this is a means by which we can give very, very high doses of radiation, but spare other tissues that are nearby. And on the right here, you'll see an example of one of the older techniques for brachytherapy, where we left catheters with sources inside, and those would stay in patients for several days before they're taken out. And this is just how it looks on a radiograph. And then here, this is an isodose contour. And so you kind of look at this, think of this like a topographic map. The height, these higher points here represent the highest amount of dose, whereas this shows as these lines get further and further apart, the dose is decreasing. So everything in this area is getting a very high amount of dose, but then it falls off quickly as we get further away. And brachytherapy is a very old technique. I mean, one of the randomized trials that really justified its use was back in the late 80s, early 90s. And this is where patients were treated with extremity or superficial trunk sarcomas. They underwent surgery, and then they either received brachytherapy with those implanted beads or were observed. So these are iridium-192 is the radiation source that were used. And these radiation sources gave off 42 to 45 gray. gray over about 4 to 6 days. And so gray is the unit of radiation. That's the amount of energy that's absorbed by the radiation per unit mass. And the brachytherapy techniques used back then significantly improved local control, so preventing the tumor from coming back in the area where the surgery was. It's a pretty dramatic difference. 82% with brachytherapy had control versus 69% without. And this difference was even more notable for patients with these higher grade. So going back to what the pathologists were speaking about earlier, higher grade aggressive disease. In that case, the difference was 89 versus 66%. There wasn't an impact at all for a low-grade tumor, so that does play into who we recommend brachytherapy for. And it didn't make a difference in terms of metastasis or survival. This is purely a local control benefit in terms of helping to preserve that limb. And we learned a little bit about timing back then. So when we loaded the sources really early, there were more wound complications seen. But if we waited until a few days after the surgery, post-operative day 5, and loaded it, there was a significant decrease in wound complications. So this was what heralded the use of brachytherapy in extremity sarcoma. And we'll talk about retroperitoneal sarcomas a little bit later. But then we've also seen that brachytherapy is not necessarily right for everybody. So a comparison study that compared brachytherapy versus beam radiation, and a specific type of beam radiation called intensity modulated radiation therapy, or IMRT. IMRT is a technique where we can actually shape the beams, the external beam radiation fields, to shepherd the dose towards where the tumor is and reduce the dose to other structures that we want to protect, like nerves, like bone, or like internal organs, like that we see in retroperitoneal sarcoma. And they compared patients who had brachytherapy following surgery to patients who had external beam or IMRT as part of their treatment. And the IMRT group, or the external beam group, actually was a little bit more aggressive. They had more positive margins, bigger tumors, and more overall aggressive surgeries. And in that one, they saw that the 5-year local control, again, the prevention of the cancer coming back in the area where the surgery was, with beam radiation was 92%, while brachytherapy was 81%. So in general, this is one of the reasons why we tend to use beam radiation more than brachytherapy. But there are still some times when brachytherapy definitely has a strong indication. If a patient's already received beam radiation therapy, brachytherapy is much more localized and can deliver the dose more precisely. Some patients just aren't able to come in for the amount of time it takes to give beam radiation therapy. And so with a careful discussion with the patient, you can choose to use brachytherapy instead of beam radiation, just understanding that it may not have as high of a control benefit. And so in terms of preventing the cancer from coming back. And so brachytherapy really does provide a very targeted distribution, a lower integral dose. When beam radiation has to get to a tumor, it has to go through all the tissue to get there, whereas brachytherapy catheters are already in the position where they need to be to deliver that dose. So it's particularly beneficial in terms of pediatric patients, where we really want to limit the amount of body radiation dose they have to prevent the risk of a secondary cancer. And for patients who've already received radiation therapy. And it can be combined with external beam radiation therapy for residual disease. This is where it's a boost, and we'll talk a little bit more about that later, and can be used as a therapy all on its own. Although, again, like I said, there's that caveat of external beam versus brachytherapy as an approach. And one thing that really has to be taken into account when you're thinking about your patients is that dose fall off is great if the tissue, if there's an organ that's a centimeter or so away, but if there's something that you need to preserve that's right where the brachytherapy would be delivered, it can get excessive amount of dose. So I'm always very careful with brachytherapy if it's up against a bone or up against a nerve, because those will receive a huge amount of dose, which can damage them. And we also have to make sure it's offset a bit from skin, because we don't have these really high doses hitting the skin, because that can cause a burn, or it can cause a graft to fail if a patient is being reconstructed after surgery. So modern techniques don't use those permanent seeds very often, although there is a bit of a back to the future in some cases for these. So catheter placement is done with an afterloader that actually runs a very, very high intensity source in and out of catheters that are placed. When we place these catheters, we do it very, very carefully with the surgeon. And when we place the catheters, we want to be very careful not to contaminate anything. We don't want to be spreading any cancer cells around. So when I introduce these catheters, you see on the right, there's a number of little catheters with buttons. Those are the tubes that deliver the high-dose radiation therapy. Those are introduced using these hollow needles called trocars. And we actually place those needles in far away from the tumor, always going towards the tumor to run the catheters through so that we're not potentially tracking any cancer cells back. We sew these little catheters to the skin with little buttons, and we do multiple layers to give a more complex dose distribution using Surgicel or with other drains to kind of to stagger them out. And this helps us to spread the dose out, avoid having any place to be really hot, and so that we can get a nice uniform and safe dose distribution when we're doing these implants. And these can be closed, as we see in this case, where the patient has a closed incision, but it can also be done with a vac in place so that we can treat the tumor bed, but avoid giving any dose to the skin. That's one of those, like Dr. Roberts was talking about earlier, the staged surgeries where you do the surgery in two parts. And so these are examples of the stage reconstruction. On the left here, this is a patient who has their catheters placed with a wound vac in place, and the treatment will be delivered, and then this wound will be closed later. Whereas in this one, this is an immediate reconstruction, and so which can be much more complicated, and we have to be very, very careful not to give excessive amounts of doses to the flap that would cause it to fail. And so, and while stage reconstruction does sometimes have a longer inpatient stay, it could reduce the rates of wound complication and failure. So ultimately, this can be better for the patient in terms of avoiding repeat surgeries to fix injuries from radiation. And so an alternative to these high dose rate catheter-based brachytherapy is stranded seed brachytherapy. So this is actually kind of going back to what was done in the past with the iridium catheters, but these actually stay in the patients. These are permanent stranded seeds. So using cesium-131, this is a source that has a short half-life of about 10 days. We can place these seeds in. They will give off their radiation, and then they'll go cold. They will stay in the patient, but they can give off their dose, and then you don't have to worry about pulling catheters or anything later. But it's so this can be an elegant approach for depositing the radiation within a patient. So all of those were kind of approaches where surgery happened and the radiation tends to happen afterwards. IORT is where all the radiation tends to happen during the surgery. So this allows precise delivery to therapeutic dose to the area where we're most worried about those positive margins. And it does it all while the patient is on the table. And so, and just like other brachytherapy approaches, it bypasses the need for beams of radiation to go through healthy tissues, which again is potentially very beneficial for patients who've already received external beam radiation therapy, or in pediatric patients where we're trying to reduce their overall integral body dose, and so to avoid secondary cancers. There's a lot of different ways of giving IORT. These are two examples of electron beam accelerators that actually are in the operating room. These are accelerators that kind of get built in, and they treat the patient during the surgery. They are very expensive, and they're very limited in terms of the directions where they can direct the beams. And this is a technique that was used at University of Washington, but we moved away from. There's orthovoltage systems that use low energy photons. There's high dose rate brachytherapy, which is that same technique with the afterloader that we spoke about, and I'll show a picture of that a little bit later. And then there's also permanent brachytherapy that can be done during IORT, where some of the radiation is given during the surgery and some happens afterwards. And those are particularly beneficial because you don't need any shielding in the operating room to deliver it. And so you could do it in any OR, whereas all these other approaches need a special shielded, one-of-a-kind type of operating room that's just really not available everywhere. IORT is also a technique that has been around for a while. And one of the original trials in retroperitoneal sarcoma randomized patients to external beam and IORT versus just external beam. IORT was delivered using electron beams, and they saw significant benefit in terms of local control in retroperitoneal sarcoma. So not like the extremity sarcomas we talked earlier. It's decreased the chance of local regional recurrence by in half, from 40%. They only had 40% local regional recurrences versus 80% with external beam, and fewer GI complications as well, although there were some nerve injury in the IORT group. So that kind of established IORT as a technique that can be used for retroperitoneal sarcoma. This is an example of that intraoperative HDR afterloader applicator. So this is placed right in the cavity during surgery. It's hooked up to a robotic loader that puts a seed in and out of these catheters and delivers a very, very high dose during the treatment. This does require a very special shielded operating room for us to be able to use it. And this is a very well-tolerated approach. We've used it in adults and children. And so with excellent degrees of local control, 74% in retroperitoneal sarcomas for adults, up to 86% in kids. But again, limited by needing a special operating room. And surgical technique definitely has benefits. A study that was actually comparing external beam approaches, which did a margin boost where they give extra dose to the margins with protons. They had an incredibly low rate of failures, although the follow-up is relatively short. They only saw a 3.33% crude risk of failure. So this shows that even in the modern era, with modern surgical techniques, with modern staging, that giving that extra boost, and so it definitely seems to have a benefit in terms of preventing the cancer from coming back. And so one of the techniques that we're looking at now to make it easier to do this IORT treatment in any operating room at any of our sites is with a monodirectional palladium source. This uses palladium-103, which is, again, it's a radioactive element that gives off radiation therapy to the operative bed. It's on this little matrix that you can really sew into place. It's got gold on one side, so the dose is directed in one direction. So you see down here, you see this cloud of dose going off in the direction that the palladium sources are facing. But on the other side, where the gold is, there's a really, really sharp dose fall off. And this allows us to treat an area at high risk of failure while really protecting the bowel, the rectum, the small bowel right next to it, delivering a very, very low dose of radiation therapy. And it's been investigated in the retroperitoneal sarcoma setting using a boost, giving 20 to 60 gray at the time of surgery by sewing this little film into place with these palladium-103 sources at areas where there's concern for positive margin. To date in the study, although it's very, very early in the follow-up, they haven't seen any local recurrences yet on their study, although the median follow-up time is only 16 months. So time will tell how much benefit they're seeing, but this is an excellent way of giving a boost of a high dose of radiation where we're most worried about failure while sparing other tissues nearby. And here's kind of an example of this source in place. And right next to it, this is a CT scan, and all this stuff that's right next to it, that's small bowel. And it's highlit using some oral contrast. But you can see that these beads that are in place with the CETA sheet, it's giving a large amount of dose right here, where, if they'd resected further, they would have had to take out nerves, the sciatic nerve and such, to really get a negative margin. But on the other side, where the gold is, the dose falls off very, very rapidly. So we're looking to implement this throughout the UW system. And then our last topic, we'll talk about adaptation. Sarcomas, when they're treated, are known for changing significantly in size. And so there was a large trial in which we saw a lot of this, the Pathology study that looked at the combination of pazopanib and radiation therapy. They considered a size increase as a failure. And actually, a number of my patients who were treated on this study were considered to have failed because their tumors grew. But in all but one, at the time of surgery, when they took the tumor out, there was no vital tumor left. Everything was dead. So fortunately, they dropped that endpoint, and they had a really, really good response on that trial. So we'll be seeing potentially some more use of that later. But here's an example. This is a preoperative radiation therapy plan, where the dose is sculpted to keep it off of the bone, and it's covering the tumor with a high dose in this red area. But during treatment, about 14 fractions in, this tumor increased significantly in size, and the tumor is no longer within the radiation field. And this is a concern because our initial plan is no longer covering the tumor. So tumor volume changes occur in over 50% of patients. About 10% are going to require some adaptive planning. And so when we can do some techniques to reduce the chance of that, robust treatment planning is to plan something anticipating change. And this is an approach that can help to reduce hotspots and under coverage. And adaptive planning is one that looks at these changes and then just changes the plan to address target coverage issues on treatment. And this is especially important because we're moving towards treating smaller volumes with radiation. That was the effort done on a recent RTOG trial that was testing the effect of reducing the size of radiation fields. And the technique that we have, so we actually have this new system at UW called the Ethos system that allows for rapid replanning of radiation plans to accommodate for changes in size. Tumor size increase can result in undercoverage, and that can risk local failure. Tumor size decrease can result in hotspots that can contribute to fibrosis and wound healing issues or even fracture of weight-bearing bone. So there is a clinical benefit to doing these types of treatments. And so this is the system that we're working on here at UW to integrate adaptive treatments into sarcoma. And that's all I'll be talking about today. And so I'll finish up there. Try to leave some time for questions.
Thank you so much. Please place your questions in the chat. I see the first one. Can this technology, I believe this is referring to the brachytherapy technology, be used to treat non-resectable lung sarcoma lesions that are blocking oxygen pathways?
So yes, there's a form of brachytherapy called endobronchial brachytherapy that I do with the pulmonologists. And in that, we bronchoscopically place a catheter directly into the airway. And then we can plan to treat a segment of airway with very, very high doses of radiation therapy, either to palliatively stop bleeding or even to treat the tumor. We currently don't have that here. That's something that I need to work on in terms of having a shielded operating room to do that. But yeah, it has been used, endobronchial brachytherapy, and it is an effective way of treating airway lesions.
Thank you. All right, next I would love to introduce Dr. Shannon Fogh, who comes to us as an associate professor and of the Fred Hutch and University of Washington, and the director of our Integrative Medical Oncology Clinic at Fred Hutch. And she is a specialist as well in the treatment of brain metastases and CNS disease. And she will be speaking on integrative oncology for sarcoma patients.
Good morning, everybody. Making sure you can hear me. I'm just going to share my screen and my slides.
We can hear you well. Your slides look great.
Perfect. Thank you so much for the introduction. My name is Shannon Fogh. I'm actually originally trained as a radiation oncologist, and several years ago did a fellowship in integrative medicine because so many of my patients were asking what else they could really do to complement and synergize with their conventional treatments, and knowing that we have really great evidence for our integrative approaches actually leading to not only improved outcomes, but helping with quality of life. And I work with a fantastic team. Our director is actually Heather Greenlee. I'm one of our integrative oncologists and work with a team of NDs and acupuncturists, and just a really wonderful service that we're able to offer patients. So this is a brief background of what integrative oncology is. We think about this as a patient-centered, evidence-informed field of cancer that utilizes mind-body practices, natural products, other lifestyle modifications, and again, alongside our conventional cancer treatments. We are aiming to optimize our patients' health and quality of life, and across the continuum of our cancer care. So not only during treatment, but in survivorship as well. And this can include, as I mentioned, our mind-body approaches, nutrition interventions, supplements, and exercise, and I'll talk a little bit about each of these. This is a short amount of time to go through all of these buckets, but hopefully enough to get people, a little bit of a flavor for each of these areas. And I'm going to start with supplements because in spite of the fact that we actually have some of the weakest evidence for supplements, most of our patients, about 80% of our patients, are taking supplements at some point during or following treatment. So important for us as clinicians and as patients to be aware of what things that we want to be thoughtful about supplementation. Just because something says it's healthy doesn't mean it can't have side effects, and we want to be aware of those. Thinking about things like, is a supplement an antioxidant? Can it be a blood thinner, have anticoagulant properties? Can it stimulate the immune system, which can be a problem for taking or have systemic therapies that are trying to impact our immune system? Can they worsen symptoms or even worsen cancer outcomes? And so these are things we want to take into consideration. Just briefly about antioxidants, relatively benign sounding supplements like vitamin C or turmeric can have really strong anti-inflammatory, antioxidant properties. And when patients are getting radiation is actually designed to impact our tumor's DNA by creating free radicals. And we want to make sure that we're not giving high doses of supplementation that can undo some of this and potentially make the radiation less effective. If patients are taking blood thinners or other medications that can impact their blood, we want to make sure that we're aware of supplements that can further thin the blood or be anticoagulants. And again, relatively benign supplements like vitamin E, fish oils, turmeric, things that patients often will pick up over the counter. We want to make sure also that we're not having supplements that can actually worsen our risk of cancer. And even our alphabet vitamins, A, B, C, D, and E, have some of them have shown increased risk of cancer. For example, vitamin A has been shown to increase the risk of lung cancer. Vitamin E has been shown to increase the risk of prostate cancer, as well as selenium. And some of our supplements also can interfere with some of our pathways that our chemotherapy or systemic therapies are working on, and we want to make sure that those are not impacting the efficacy of those therapies. We also want to be very careful about probiotics. Everybody's talking about probiotics, and that these are things that patients should be taking. We want to be careful if our patients are in an immunocompromised state, taking corticosteroids on certain chemotherapies that can drop counts, and even with some radiation. So making sure that we are careful with probiotics during those situations, as well as when patients are having their indwelling medical devices, even patients with a history of diabetes. So just making sure that we're not using probiotics during these more vulnerable times. And here are just some of the contraindications that we see again in some of our most common supplements that otherwise can seem relatively harmless. I will just briefly mention also liver function. When a patient comes in and their liver function has bumped up, always important to ask if they're taking supplements, because this can be a contributing factor, and we don't want to always assume this is the chemotherapy or another cause. Certainly some of our supplements can contribute to this as well. It's rare, but I have had patients where they've almost had to stop a certain form of chemotherapy, and it turned out it was a particular supplement that was contributing to this. We also want to make sure that we're taking the right kinds of supplements. Not all supplements are created equal. They can vary based on the quality of the plant material, where and when, how it's gathered. And there can be a discrepancy between what's in the supplement, what the manufacturer says is in the supplement, and what's actually in the supplement. Supplements can also contain unwanted and potentially harmful ingredients, mercury, arsenic, lead. We want to make sure that we're not taking supplements that have some of those potentially harmful components. And here are some of my resources that are available to check. I'm a big fan of some consumerlab.com down there at the bottom. They test supplements for quality, again, making sure they have what they say they have in them, don't have things we don't want in them. They also test foods, flax seeds, chocolate. And so this is a great resource and available for both clinicians and patients. We also have a wonderful team of pharmacists that I work closely with that help look at supplements and any potential interactions of those supplements with their systemic therapy or other cancer-directed therapies. And we do have evidence that some supplements can be helpful. I'll talk about vitamin D later in the talk. We see good evidence for ginger and, to be used to help with nausea and vomiting. Importantly, combined with patients' antiemetics, we don't want patients stopping other traditional therapies or conventional therapies and trying to do this all with supplements. But we do see a benefit of ginger added to our conventional antiemetics. American ginseng can also be used to help with fatigue during treatment. And a lot of my patients have found CBD, THC products to be beneficial, but and these can be for symptoms for nausea, appetite, neuropathy, anxiety, insomnia. But important to have the dose and the type of the product be vetted and be appropriate for the patient. I can't tell you how many patients I've had say a family member brought over this and I took it, and for 2 days I was completely out. I work really closely with a group of pharmacists, and this is their information here that think about how do we tailor the dose and type for our patients. If we treat it like medicine, it can help us like medicine, is their philosophy. And then while everybody, as I mentioned, thinks about supplements, we actually have really great evidence for other integrative approaches, mind-body approaches, exercise, and just some of the benefits we see with mind-body approaches include helping with depression and anxiety, helping with cognition and brain fog, helping with fatigue, and even with balance and flexibility. We even see benefits lowering cortisol, lowering inflammation, and even increasing some of our good brain waves. And this was a study that looked at the ongoing impact of patients who are participating in a mindfulness-based stress reduction program. They actually found significant benefit on quality of life, but also in decreasing these daily cortisol levels. We know chronic cortisol can lead to downstream inflammation, and inflammation is at the heart of so many of our chronic diseases. This was another study showing just a 4-week mindfulness-based program and how this was decreasing several inflammatory markers, including interleukin-6 and tumor necrosis factor alpha. And as I mentioned, we can see a benefit on these good brain waves as well, and improved cerebral blood flow. Brain fog is such a common thing that we see in our patients. So this is something that can help with our brain function as well. And there is so much that's under this umbrella. We want to tailor the mind-body approaches for our patients, everything from mindfulness meditations, compassion-based, our movement strategies like Tai Chi, yoga, or Qigong, even breathing techniques can be helpful for activating that parasympathetic system. And as I said, one size does not fit all. Many of my patients, if they are struggling with executive function and brain fog, have trouble sitting down and trying to do a traditional meditation and feeling like they have the attention to try this. I do always stress that it's the practice of meditation. It's not meant to be perfect, and that it's okay to microdose. Doing things in shorter amounts of time. A lot of the apps are now offering 5-minute meditations, which I think is great. It really takes down that barriers and making this more accessible for patients. And I'll stress that even being in nature, being outdoors, or doing something artistic can activate this part of the brain that it can put us in a state. If we were to put probes on the brains of people doing classic meditation, doing something creative, doing something outdoors, we can actually get to the same place. Trying to create a routine or even accountability with somebody in the community or a friend can be helpful. And again, and this goes with all of our integrative approaches, having a forgiving, compassionate, and non-judgmental approach, because we're just trying to find strategies that can be helpful, and it is a journey. Acupuncture can be a wonderful adjunct to therapy as well. There's so many benefits to acupuncture, including decreased fatigue, improved sleep, reduced stress and anxiety, reducing pain. And we have a wonderful team at Fred Hutch that does acupuncture. There's many places in the community that our team is vetted as well, and important to recognize that our insurance often covers this. Exercise is another thing we have great evidence for. This is improving functional status in our patients, quality of life, cognition, even survival. And our recommendation, which comes from the American Cancer Society guidelines, is about 150 minutes per week. And again, we're seeing this benefit even survival. It can help increase something called brain-derived neurotrophic factor, which can help with our health of the hippocampus, and again, helpful for brain fog. Even one bout of exercise can increase our brain-derived neurotrophic factor and increase dopamine in our endogenous opioids. And because fatigue is such a common symptom our patients describe, important to recognize that exercise actually helps with this. It helps make better and stronger, more mitochondria, which are our body's energy powerhouse. And exercise is a great way to be able to do this. And as I mentioned, can also impact survival. Again, with not a lot of, we don't have to go to the gym for 2 hours every day to see this benefit. And I'll just stress any movement counts. So think about Richard Simmons and just sweating to the oldies, really anything that gets people moving is a great thing to include. I'm going to briefly just mention the microbiome because it's something everybody's talking about and our patients are coming in and asking about it. So why are we thinking about the microbiome? Well, it turns out this is playing a big role on the impact of chronic disease, including our cancer. And we know that we can see changes in the microbiome, which not only precede diagnosis, but can happen after we give patients systemic therapies or other cancer-directed therapies. In fact, even stress, which is common among our patients receiving a new diagnosis and undergoing therapy, can also impact the microbiome. We see a connection between the microbiome and dysbiosis and symptoms that patients are experiencing. Symptoms like anxiety and fatigue are linked to some more prevalence of our gram-negative rods. So this is a really interesting area for us to be thinking about. It would be great if we had the perfect probiotic and plan in place where we can look at dysbiosis and where patients are lacking and match that up. And we're just not there yet. But these strategies, exercise, nutrition, vitamin D, mind-body approaches, and sleep can positively impact the microbiome. So this is what we talk to our patients about. And I'll mention vitamin D. This is such an important thing across cancer for our patients. It's critical for the microbiome. When we see lower vitamin D levels, we see deficiencies in butyrate production, which can lead to gut permeability and more inflammation. And again, a lot of benefits in our patients. And even in San Francisco, where I came from, about 75% of patients I tested were low in vitamin D. So this is an important thing for us to be checking and supplementing in our patients when necessary. And even a 12-week course of vitamin D can actually positively impact the good microbiome. So this is something, again, we're seeing benefits, but also in the microbiome. I've already mentioned all the benefits of exercise, but we see it also positively impacting the microbiome as well. Sleep is helping with our microbiome. A study looking at patients with breast cancer, women with sleep disturbance had a higher proportion of the types of bugs that caused more dysbiosis. So prioritizing our sleep can make an impact as well. And in nutrition, what we eat makes a big difference. This was a study that looked at a 10-week dietary intervention of fermented foods. And at the end of that 10-week intervention, we saw an increase in microbiota diversity and decrease in inflammation markers. So having patients have both dairy sources of probiotic foods, yogurt, kefir, as well as non-dairy probiotic foods like kimchi can be a helpful adjunct to their nutrition. And this was a study called the American Gut Project. They looked at patients, over 10,000 patients in their stool samples, and found that patients who ate a better variety of plant-based foods had a much healthier microbiome. And plant-based foods included fruits, vegetables, but also nuts, seeds, legumes. And importantly, it wasn't portions. 2 basil leaves counted as part of that food variety. So encouraging patients to have a good variety of plant-based food is important. And this brings me to my last topic, which is the controversy we see quite a bit with patients thinking that they need to pursue a ketogenic approach to be able to address their cancer. And this was a great paper out of JAMA Oncology that looked at the comparison of the studies that had used ketogenic approaches versus a whole food plant-based approach, which is what our group is recommending. And what we see is with the ketogenic diet, we do see decrease in glucose, decrease in insulin, weight, and inflammation. And these are all great things from a cancer perspective. But we actually get all of these components with the whole food plant-based approach. But additionally, we get fiber, which has been shown in multiple studies to reduce cancer risk, increase butyrate, increase phytochemicals and flavonoids, which are anti-cancer as well. And still, again, being able to capture all of the positive things of the ketogenic approach. There are complications with ketogenic approaches, including uric acid accumulation, kidney stones, constipation. If patients are really thinking this is what they want to do, in spite of the other evidence, making sure they're working closely with a qualified nutritionist or dietitian. And I'll just briefly highlight this study looking at patients who underwent a very strict ketogenic and fasting approach compared to patients who had a whole food plant-based approach. And there wasn't a difference between these groups. What came out as different is their average glucose levels. So the ketogenic approach may be one way that we can modify metabolic or glucose levels, but we can be thinking about other strategies in our patients. Is simple things like the order in which we eat our food, having your fiber first, your vegetable first, allows to mop up the sugar, keeps insulin from coming in, creating insulin resistance. Same thing with 5 or 10-minute walk after a meal. This can have the skeletal muscle take the glucose up, again, keeping insulin from overdoing it and creating insulin resistance and downstream IGF-1. So these are simple strategies that we can give to our patients that isn't asking them to go through an intense ketogenic approach, particularly when they're receiving therapies that can already make getting nutrition challenging. Glycemic index of foods is another thing we can be looking at. A white potato hits our bloodstream the same way as a spoonful of sugar. So are there foods? Interestingly, a sweet potato is about half of that purple potato even left. So we can have, by choosing our foods, also be helping to modify the sugars, again, without putting patients through an intensive ketogenic strategy. Thank you so much. I'll stop sharing and happy to answer any questions.
Thank you. That was great. We do have a few questions in the chat. They're from different parts of the talk, so try to pierce them out. So from the earlier portion, I think this was maybe in relation to when you were talking about supplements. It says, are these the strategies you're describing, are they concurrent with treatment or even after treatment is finished? I presume maybe in relation to some of the potential toxicity or safety of these.
For supplements, you mean?
I believe so. That seems to be when it came in.
Yeah,
But
no
that's
problem.
the question.
Yeah, that's exactly right. So, for example, when patients are getting radiation, we want to take away all potential supplements that have that anti-inflammatory, antioxidant effect. Having our pharmacy team look closely at where supplements are interacting with the chemotherapy or systemic therapy. Those things can change. So when patients come into the survivorship space, those supplements may be absolutely fine, but we want to be thoughtful about where we're at during those places. I have supplements, that can also decrease seizure threshold in my patients with brain tumors. So when they're, at higher risk, those are supplements we want to, not have them take. But if they're seizure free for many years, that, we can always revisit this.
Great. I'm going to combine the next 2 to 3 questions, I think, into one. So the questions were, are there supplements that specifically benefit sarcoma besides vitamin D, as you mentioned? And then with the research that keto diet may have some anti-tumor properties, can you speak on this? But there's a more broad question that basically says, is a patient kind of left out there to learn all this stuff on their own? Or alternatively, how do you get to work with somebody like you and what's the kind of process for maybe hearing that more formally?
Yeah, so I may have to re-ask with the second and third part. For the first part, vitamin D is something we have the best evidence for. What happens, and I totally appreciate the comment when patients are going to the internet, is there's a lot out there that may be lab-based or in vitro or in vivo studies. And the thing is that we don't actually know how to translate those into beneficial outcomes. And I'll just give you an example. There's a lot of interest in some of the pet dewormers that patients are coming asking about. And we don't yet have the data that has been studied in humans in the randomized trials. And importantly, I've had patients who have then tried to get a dose of this, but it was a dose meant for an animal, like a large animal. And that I've had a patient who ended up in the ICU from that. So I guess going to the last part of the question, our role here at Fred Hutch Integrative Oncology is to help distill what are the top evidence-based integrative approaches that are customized for the patient, so the patients don't have to go to the internet and really struggle and sort through all of that data. And we welcome all questions. We're never going to say to a patient, nope, that's ridiculous. And we're always open-minded. We're always learning new things, but we at the same time want to make sure that we're recommending the best evidence-based approaches. And then I think the middle question was around the keto. I completely agree that sugars and metabolic health are linked to cancer outcomes. There's a loop between inflammation, IGF-1, insulin resistance that I can say impact cancer outcomes. But approaching it with a ketogenic approach may not be the only way that we can address those glucose levels. There was that study I showed where people did the keto approach versus whole food plant-based, and it was those average sugar levels that made the difference. So those are things I talk with patients about, because if somebody is nauseous, not getting enough calories, in the middle of therapy, we do not want to further stress their system by trying to have them do a ketogenic approach. And again, we don't know if that's the only way we can get to this healthy, good metabolic place, which I do agree is related to cancer outcomes.
Excellent. Thank you. All the more reason to check out the Integrative Oncology team here at Fred Hutch. Thank you again. I will move on to introduce our sponsors for the last segment of the talk. So the first, I have the pleasure to introduce Joe McNeal, who's the Executive Director of the Northwest Sarcoma Foundation. Tomorrow, I learned she'll actually celebrate 5 years at the organization, so that's really exciting coming up. And I actually myself have the pleasure of serving with Joe on the board of directors for Northwest Sarcoma, and can attest to her dedication to its mission to provide hope, education, and support, helping patients and families with sarcoma in our region. So with that, I will turn it over. Thank you.
Thank you so much. And I'm honored to be working alongside all of you. Many of you have been participating in our researcher update nights, have participated in our patient education nights. And you guys are absolutely amazing. So let me share my screen here. Hang on. Gotta go find what I'm looking for. And then I think I need to make sure that you're seeing this one. Okay, are we seeing it properly?
You need to swap it.
Swap, yeah.
Say it again, swap it again.
Yeah.
All right, there we go. It's always a debate which one I'm seeing. So Jeremy already shared with you our mission, which is to provide hope, education, and support to anyone affected by sarcoma in the Pacific Northwest while investing in research. So, and some of the ways that we do that, we provide financial aid and care packages to patients. We've had an exponential growth in our foundational grants over this last quarter. And also our care packages. So people are becoming aware of the program that we have. If you have questions about whether you're eligible for any of these things, please do speak with your physician, who can then refer you off to a social worker or patient navigator who will have to apply on your behalf for either one of these. But again, we are here to make sure that patients do not face sarcoma alone. With that, we also provide education and research, which I just mentioned. So who we heard from today, Dr. Eleanor Chen, is presenting in June on what are biomarkers, because we've been hearing a lot, not necessarily today, but in general, about biomarkers. And we have a researcher update night coming, or patient education night coming up in April, which is Clinical Trials 101. And I know we heard a lot today about clinical trials. And in this, Dr. Michael Wagner, who was with Fred Hutch, now over at Dana-Farber, will be sharing on clinical trials and maybe what to ask your patient, what to ask your physician, and how you can participate in a clinical trial. And we find those to be, obviously, just hearing today, extremely important in the advancement of care for our sarcoma patients. And how you can support and participate with us. So in this region in Washington State, we have a Friends Crawl coming up in Woodinville on Thursday, June 26th. So if you're a big Friends fan, please come out and join us. It should be a fun night. And then also in September, which you have the opportunity to even see many of your sarcoma physicians out at our Dragon Slayer Fantasy Dash and Strut. This is our first year for this particular style, where it is a run and a walk, and we are encouraging all of you to dress as your hero or your villain. We will have a villain zone that you have to go through and a hero's village when you come back. So hopefully you'll be able to join us for that event in September at Magnuson Park. And again, I just wanted to say thank you to all of the physicians who support us, do educational nights for us. You guys are amazing. So thank you so much.
Thank you, Joe, and thank you, obviously, for all the work you do for the for our sarcoma patients in the region. Do check out the Northwest Sarcoma Foundation. Next, I have the pleasure to introduce Natasha or Tasha Nathan, who herself a sarcoma survivor, is the program manager for engagement and advocacy at Sarcoma Foundation for America. She's also the Adolescent and Young Adult and Adolescent and Young Adult or AYA committee member for the Sarcoma Foundation of America. And this, as you'll hear more, is a nationwide organization that promotes sarcoma research and provides education and resources to patients diagnosed with sarcoma. So thank you, Tasha.
Thanks so much, Jeremy, for the introduction. And actually quite a full circle moment to be here with you all today. It was actually 3 years ago exactly today that I was diagnosed with embryonal rhabdomyosarcoma. So really happy to be here with you all on many levels. But let me go ahead and share my screen and tell you a bit about the Sarcoma Foundation of America. So let's see. Can you see this from the slides? Okay, great.
Looks perfect.
Amazing. So as Jeremy said, I am Natasha Nathan. I'm the program manager of engagement and advocacy at SFA. So to tell you a little bit about our mission, simply put, it's to improve outcomes for people diagnosed with sarcoma by increasing the number of survivors. And there are many ways we do that. Our most prominent way is by funding and advancing research. We really believe that the pathway to a cure is investment in research. So that is a fundamental priority at SFA. We also educate and provide resources for people diagnosed with sarcoma and their families. The more we can educate patients and their families, the more empowered they are to participate in their care and the sarcoma landscape in general, so that we can all work together to advance outcomes. We also advocate on behalf of the entire sarcoma community. We are the leading organization working on public policy on Capitol Hill. And we really try to be the collective voice of the sarcoma landscape. So partnering with other organizations, patients, survivors, their families, medical professionals. We are, the collective voice for everybody impacted by sarcoma. We also work to grow awareness, of course. So for sarcoma being a rare disease, we always say that we're the biggest of the rare, but we are still rare. And awareness leads to more education, more research, better treatment options, and better outcomes. So these are our three main pillars at SFA. Research, education, and engagement falls under that, as well as advocacy. In fact, engagement falls under all of them. But before we get into the pillars, I'll talk a little bit about how we began. We were founded by Dr. Mark Thornton, Patricia Thornton, or Tricia, and Dr. Jack Brooks in 2000. And this was after Mark and Tricia's 3-year-old son was diagnosed with sarcoma. They found that there was no national patient advocacy and research organization dedicated solely to sarcoma patients and their families. So they sought to fill that void. At the time of SFA's inception, one of our founders actually worked at the FDA and another worked at UPenn in clinical trials. And they really understood that research funding and changes to regulatory pathways to get new treatments to the market were necessary to change outcomes, and especially given their professional and personal experience. So SFA really started in the basement of the Thorntons' home and is now the largest, most comprehensive sarcoma patient organization in the US and globally. We are not subtype specific. We are pan-sarcoma. We represent all over 100 subtypes and patients. And we really, have a mission to elevate the patient voice and bring together the entire community, forging strategic partnerships rather than recreating the wheel in the sarcoma landscape. So as I mentioned, research is incredibly important to SFA. SFA is the largest sarcoma-specific private funder of research. And if I go to the next slide here, you can see a map of where our funding actually is. So we do fund research both in the US and globally. We have invested over 26 million in research, over 200 grants at 137 institutions and over 150 researchers. So we really do have a large investment in this. Another interesting thing about the research, we have a lot of different opportunities for researchers to receive grant funding. We like to invest in researchers who are really starting their career to help them get that off the ground and get their research going. So we this year received over a 50% increase in grant applications, which might have something to do with the government funding freezes. So we do receive quite a bit of grants as of late. So education is another very important pillar to SFA. As I mentioned before, an educated patient is an empowered patient. So we offer many different ways for folks to engage with us in that regard. We have in-person education sessions with esteemed speakers, lots of interactive webinars. We actually just had one this past week about public policy, but we have done a subtype series. We continue to do those. We talk about updates in clinical trials and research. So lots of interactive webinars where you really have the opportunity to ask questions of the experts, which is really important, especially given that not everybody has access to a sarcoma center, and we want to make that as accessible to people as possible. So lots of interactive webinars. We have an advocate and researcher network at national meetings. In fact, our CEO is actually currently at ESMO in Lugano, meeting with other organizations and medical professionals in the sarcoma community abroad. And we do briefings on the latest developments in sarcoma research. Another part of our education that I work very closely in is our resources. And this is really where I feel patients can come, receive resources, and feel empowered to be collaborative with their team and their care and really become advocates for themselves. We just recently launched this sarcoma diagnosis question guide, which can be found on our website. And I'm happy to share with Fred Hutch to send out with these slides afterwards. But this was something we worked really hard on and worked with a patient and care partner focus group to really think about the questions that you should be asking when you have a sarcoma diagnosis. And while we hope this reaches anyone who's just been diagnosed, it is a really great resource for medical professionals to also sit down with their patients and make sure you're going over these questions that are important to ask at the start or at any point in time in treatment. We recently also launched our Sarcoma Stories podcast, and that was born out of the realization that there are so many wonderful podcasts that talk about clinical trials and research, which are incredibly important, but there was no space for sarcoma patients specifically to talk about their stories and learn from one another and feel less isolated in the community. It is a very isolating diagnosis. And so we wanted to change that landscape of podcasts and bring the patient voice to the center of it. And it so far has 8 episodes launched. I believe we have at least 15 in production, if not more. But a really awesome opportunity for patients to share resources and for medical professionals to really hear the voice of the patient and what is top of mind to them as they navigate their treatment, and care partners. We have care partners on the podcast as well. Lots of Facebook groups to join. We have a care partner specific one where you can connect with other sarcoma caregivers. We have an adolescent young adult Facebook group and a sarcoma stories group where you can connect with the guests from the podcast, ask questions, connect with others in the community who might be listening. We've recently revamped the website to have a sarcoma subtypes directory. So you can go and look at pretty much any subtype, look at clinical trials specific to it, look at the medical components that you might be tempted to Google, but we know Google is not always the best place to go down a rabbit hole. The sarcoma subtypes page is a much better place to do that. We've selected the information that you need to know to really be a participant in your care and advocate for yourself. We also have a list of treatment centers that are dedicated sarcoma treatment centers. We actually have a very extensive process of categorizing those and making sure that they have the resources people need. And then we also have Jordan's Dream Fund, which is a fund to help people navigate the costs of clinical trials. So there are many other resources we offer. These are just a few that always stand out to me when I'm speaking with people. And then advocacy, our third pillar, is a really big priority to us in an area that I work quite closely in. We really want to be the voice for the sarcoma community and educate legislators on Capitol Hill, educating those in our government who make policies and are the voice of their constituents on what sarcoma is, why it needs more funding, why it needs more attention in public policy, and how those policies really are impacting the sarcoma community. So we spend a lot of time educating legislators, but also working with our network of advocates. And really anybody can be an advocate. Your stories are some of the most impactful parts of advocacy, and sharing that when we educate legislators is so important. We actually have an entire weekend dedicated to it, which I'll talk about in a moment, but we also partner and work really closely with rare cancer coalitions and other advocacy groups because it is absolutely not something we can do alone. It takes all of us. So speaking of that, we do have our advocacy weekend coming up in July during Sarcoma Awareness Month. It was so successful last year that we made it an entire weekend this year. Last year, it was just one day, but this year we will have a day dedicated to being on the Hill, actually speaking with legislators with, priorities that we have actually surveyed our community on what's most important to sarcoma patients in the public policy realm, followed by an education day where we'll be discussing basically bench to market and why, and as it goes for research, and why it's important to understand that when advocating for sarcoma patients. Followed by our Race to Cure Sarcoma in Washington, D.C. We do have a series of 5Ks and 1 mile fun walks across the country. It's a really great opportunity, not only to fundraise, but to meet others in the sarcoma community. There is not one place I've gone to other than a race where I've seen everybody really come together in that way. So just a really great event to round out the weekend, and anybody is invited. So I'll open it up for questions. I know I threw a lot of information at you. I'll stop sharing my screen, but that is also my email if you would like to get in touch or would like any resources. I know these slides will be shared out afterwards, so you are more than welcome to contact me that way as well.
Thank you so much, Tasha. That was really wonderful to learn of everything that SFA is doing, as well as Northwest Sarcoma Foundation for our community, the providers, and most importantly, the patients and caregivers.
Thank you.
Well, I want to thank also all the attendees for joining us this morning, and as well as anyone who watches this later virtually. And please feel free to reach out should questions arise. Again, we'll be sharing some of the relevant talks and information as well as the Zoom recording. And we would greatly appreciate any feedback and evaluation. The link to the feedback form is in the chat. This helps us really learn from you what you would like to hear for future events and make this as tailored as possible. So thank you for joining us.